Hello, everybody in podcast land. I'm Dr. Ted Thatchencary, and this is MD Roundtable, a podcast about collaborating and learning from other healthcare professionals from all over the globe. We are all so much more connected due to technology. We have so much to learn from each other. Thanks for joining us today at MD Roundtable. This is a very special episode as we are featuring Dr. Pedro Salinas, who is a critical care physician at Aurora St. Luke's Medical Center in Milwaukee. In addition, Pedro holds advanced certification in critical care echocardiography from the National Board of Echocardiography and is also a fellow of the American Society of Echocardiography. Welcome to MD Roundtable, Pedro.
Thank you for having me. I'm really excited to be talking to you.
Yeah, my pleasure, Pedro. Just for the audience, Pedro and we actually met, I would say, geez, what, 22 years ago. We trained together at Cook County Hospital and did our internal medicine residency together. So small world, huh?
Very small world indeed.
Great, great, Pedro. Well, first off, why don't you tell us a bit about yourself, Pedro? Like, where did you grow up?
So I'm original from Mexico. So I grew up in Mexico, and the first part of my life and childhood was in Monterrey, Mexico. So it's just if you a straight line from San Antonio, Texas, is like 4 hours south. So I spent my childhood there, and then I moved to other places in Mexico, and I certainly did medical school there. But my start was actually not in medical school.
Oh, really? Okay. Okay. What did you start with?
So I initially was when I was 17 or 18, I was very interested in nutrition, and so I ended up starting a degree in nutrition, and then I transitioned to medicine.
Ah, I see. I see. Good for you, Pedro. Who was your biggest childhood influence on getting into medicine?
I'm sorry to disappoint you, Ted. I don't think I had like a big influence in medicine. Like I said, I at that time I was just interested in nutrition and diet, and then I once I started looking into that, I felt that I had to keep going and studying more and understanding the how the body works, and that led me into medical school.
That's great. That's great, Pedro. Where did you end up going to medical school?
So I was in Monterrey, Mexico, and there are several medical schools there, and Universidad de Monterrey is one of them. And so that's where I started medical school, and then at some point I did like everyone else who comes to United States, the boards, the medical exams, the USMLEs. Ended up at Cook County,
Right.
and we overlap. Yes.
Fantastic. What made you interested in pursuing a fellowship in critical care medicine? And then also specifically, how did you get interested in critical care echo?
So I had a pretty broad interest while I was in training at Cook County in internal medicine. I really was excited about so many things in cardiology and pulmonary and GI. So I started my path as a hospitalist, and I moved to different places. And at some point, I had exposure to ultrasound.
Great. Yeah, that's sort of what sparked your interest in point of care ultrasound. Was it in fellowship, I would imagine? Because I don't think back in county we were using ultrasound, right?
Well, it's kind of interesting. When I know you were more senior than me, but in what they call at that time the church stay unit,
Mhm.
they were piloting some studies with basic echocardiographic views. So I didn't have the exposure, but I knew it was going on. And some of your colleagues actually were actively doing research, but it was not at that time. It was later, actually in New Hampshire, where I was involved in the sub internship, and of course with internal medicine residents. Then they had ultrasound, and they that sparked my interest. And once I decided to move into critical care, I just found that it was an extremely important tool. and some skills that I need to refine.
That's very interesting, Pedro. Well, having said that, I think let's get into the meat of the talk here. I think it would be beneficial to discuss right ventricular failure for our listeners. I guess it used to be the forgotten ventricle, but nowadays it's the not so forgotten ventricle, would you say?
Yes, that was a discussion. It's like, why are we still calling it the forgotten ventricle? I think we talk about the right ventricle all the time. So some people say it's the people's ventricle.
I like that. So, Pedro, for our listeners, can you tell us what the importance is of the right ventricle and perhaps some basic physiology to start with?
Well, as you mentioned, I think in the past it was the I think common understanding or impression that it was just a passive conduit that everything had to do with the left ventricle. And I think lately we start to understand a little bit more about that, about the right ventricle. I think the reasons that, again, one is because we thought that the Fontan circulation, where patients can live without the right ventricle and extrapolate all that into everyone else, and that certainly was a failure, because many of the reasons that the ventricle fails in the ICU population and other population is because there's an increase, in afterload, that sudden increase. And the other thing that I think we have come across is that to understand is that, the right ventricle can fail in other situations, very commonly in patients that we have with some ARDS or mechanical ventilation, in pulmonary embolism,
Mhm,
and sometimes it's not very evident. Even in sepsis is not that uncommon, and I think now we understand that there's some of those patients that actually have these right ventricular failure. So I think we have opened that and we have better understanding, and it is through imaging that you have better understanding of the right ventricle. Otherwise it's really, really like a black box. It's
mhm.
really hard to understand it.
I agree. I agree. It is one of those areas in critical care where it's kind of difficult to understand. But Pedro, when someone has clinically significant RV failure, what would be some of the usual symptoms you would see? This episode is brought to you by Cosmos by Echocardiography, which is an all-new category of ultrasound machine that is helping clinicians around the world transform patient care by making ultrasound imaging more accessible and easier to use. Echocardiography has packed advanced features and capabilities like auto ejection fraction, auto Doppler, auto preset, CW Doppler, and more into a device that's a fraction of the cost of your traditional cart-based systems. Whether you're a seasoned expert or just starting your ultrasound journey, Cosmos can grow with your practice, offering cart level capabilities and a 5-year warranty. That's right, folks, a 5-year warranty without the cart level price tag. Podcast listeners get a free premium feature upgrade. Choose from auto Doppler, enhanced cardiac calculations, and more. Visit echonos.com/podcast. That's ECHONOUS.com/podcast. Join thousands of clinicians who've already discovered the future of point of care ultrasound. Cosmos by Echonos, because better care shouldn't wait.
Yeah, I mean, I think there's certainly a spectrum. I mean, there's sometimes these patients can have biventricular failure, but some of the, for example, in patients who come with an acute and chronic exacerbation of with significant right-sided heart failure, you can see them that their symptoms certainly can be shortness of breath, but they can be nausea, it can be vomiting. You can see some liver injury, some kidney injury, and I think those are the symptoms. Sometimes when it's an acute situation, I mean, these patients can deteriorate really fast. And you can see them sometimes they come to the unit in extremis because by that time, the right ventricle is dilated and it's already compromising the left ventricle. The cardiac output goes down, the right ventricle gets into this vicious cycle where it gets less perfusion and more systolic dysfunction. So that's, I mean, there's a reason these special, the expert says, well, we call it the RB death spiral, because actually you want to see the RB dysfunction before you get to the point that the patient is in a pre-arrest situation. So we actually have to be very open and make sure that we look at the right ventricle and not too late before it's really, really difficult to bring these patients back.
Correct, correct. Yep, that's very true. What are you mentioned earlier some of the causes, but what are in the ICU specifically, Pedro? What are some of the common causes we see of RV failure?
I think a common cause that I mean, most of us can distinguish, and it's the RB failure in the setting of pulmonary embolism. I mean, we all see pulmonary embolism,
Mhm.
and we know that it's a spectrum, and the mortality can be as low as 1% to 60%. That's why, I mean, the symptoms of RB failure, it's a whole spectrum, especially when it's acute. So this is a very common scenario of RV failure in the setting of PE.
Mhm.
Other common scenarios, and we have seen it, especially during the pandemic, during COVID, is the RV failure in the setting of ARDS and mechanical ventilation. That's very common. And I can tag into what you were saying is, and you were mentioning is, and you can tell that this has to do with an increase in afterload. So a lot of the reasons that we see RB failure in the ICU have to do with increasing afterload. So it's very different from the textbook situation or of RV infarction, when it's a pump situation, the pump is failing, but the afterload is not necessarily increased. And that's basically has to do with the properties and the physiologic characteristics of the right ventricle that makes it very sensitive to any changes in the afterload with a little more tolerance for preload in that setting of normal afterload.
Great. Thanks for clarifying that, Pedro. How common is RV failure in sepsis?
I think that we are just scratching the surface. That there's some studies that by Gary in France that shows that in their cohort, like 20% of their patients with sepsis had these quote unquote RB phenotype. So that those patients are RB dilatation and RB failure. And I mean, I was excited to hear yesterday from one of the researchers that is doing a very large study too in trying to understand sepsis physiology and different phenotypes, that is actually this RB phenotype which increases mortality.
Hmm.
So those patients with RB failure, usually, I mean, just for context for the audience and why are we talking about, these phenotypes? Just for context to understand that most of the time we think that we all fit sepsis in one bucket. And I think lately we have better understanding that not necessarily that macro hemodynamics, they can look differently. So there can be these quote unquote phenotypes. I mean, some of them have hyperkinetic LB, which is the common phenotype that we associate with sepsis. Some of them have increased diastolic dysfunction that that you can check with some measuring some filling pressures. So, and there's the LB dysfunction phenotype. So there's macro hemodynamically, not all sepsis fits in the same bucket. So
Correct.
when you are talking about these RV failure kind of phenotype, we're talking about 20 to 30%. Again, in the Gary study, they show that it's mostly the LV hyperkinetic phenotype that increases mortality, but I think there's new data that is actually the RV failure phenotype. Without getting too technical and into details, I think to me the message is that not all sepsis looks the same. And I think that we need to understand that how to recognize those differences because they have huge implications in terms of management. So I don't know how do you see this, Ted, but I would like to hear your opinion.
Well, I think you bring up an excellent point, Pedro, because sometimes, as you know, in the ICU, we call our patients sepsis-induced cardiomyopathy, right? And I'm wondering what percentage of those patients are actually, like you said, RV failure induced. So that is very interesting that there is studies coming out on this, and I'm really looking forward to what the future brings on this data.
Correct. And I think you are alluding to how is that going to impact. I mean, we don't have the studies and showing the differences in impact. We're just again scratching the surface, understanding that, there are those phenotypes and probably they require adjusting your treatment. We tend to think, okay, this patient is admitted with sepsis. It's going to get 30 cc's per kilogram. It's going to get antibiotics. But again, if you have LV hyperkinetic profile with fluid tolerance, is going to be very different than someone who has biventricular dysfunction or isolated RV dysfunction or high filling pressures. The management will have to be tweaked at the bedside with some understanding of the physiology in this particular patient. If that patient has LV dysfunction and there's some evidence that that low cardiac output is influencing, how the patient is behaving clinically, maybe that patient needs some inotropic support, for example.
Correct, correct, Pedro. Pedro, is there a gender preference to RV failure?
I'm not aware of that actually.
Okay. And being that, you use the critical care echo quite a bit, so what are the common ways to diagnose RV failure? What are some of the measurements that you look for specifically, etc.?
I think most people, I mean, again, RV dysfunction, we don't even have a good universal concept, or not concept, but definition of what it is. But usually it's a combination of RV enlargement, that's a qualitative measurement. So you can see that, on your apical four chambers, you can see that the RB compared to the left, that's a classic, way of understanding how it looks. How big is the RB? Well, if it looks bigger than the left ventricle, you know that it's really, really enlarged. And there's way of qualitatively grading that. So that's one way, just looking at how it looks on that apical four. But there's also gives you some morphological data, but some understanding of how that right ventricle is interacting with the left, is that concept of interventricular dependence. So when you see that heart in a short axis, and again, you need to learn some of those views that, in this podcast, we can't describe all of them. But in that short axis, you basically see the heart, and a short axis like a donut, but you can see how the right ventricle, how big is compared to the left. But not only that, you can also see how that septum behaves. So, how that pressure, is the right ventricular pressure higher than the left? So, that's why that septum is bowing. Is that happening in diastole, in systole? So, that gives you a lot of understanding. So, that's the morphological aspect of understanding the RV. And then another way of looking at it is how it's functioning. So the systolic function, 80% of what the right ventricle does, it's longitudinal function. So when you go to that apical four, or even what they call the RV focus view, you can see that right ventricle contracting. And usually you can visualize at the tricuspid annulus, you can see if it's moving up and down. And you can also quantify that. You can have the famous TAPSE, where you can measure that displacement, or you can measure that velocity with the S prime. So to answer your question briefly and to recap, is a combination of morphology, how it looks compared to the left side, and the size, and the other is the function. And a very easy way startup is just looking at that longitudinal function. And if you're going to ask me, oh, is that perfect? It is not perfect.
Right.
I mean, the reason that RB was quote unquote forgotten is because it's very complex geometry. I mean, unlike the LB, which is the shape is just like a bullet, and it's very easy to see and it's much easier to measure. The right ventricle, because it's a crescent shape and it wraps around the right ventricle, and the way it fails and enlarges. So sometimes when you are doing the ultrasound, you can basically insonate through an angle that you are not seeing the whole right ventricle, and you call it small while it's actually enlarged. So that a lot of people have been so hesitant to look at the RB for that reason. But it's important. I think that with some practice, I think you can look at the basic aspects of that right ventricle.
Yeah, great. Thank you for explaining that so clearly, Pedro. You mentioned TAPSE. Is TAPSE something that critical care docs, ER docs can measure quickly just with the point of care ultrasound machine?
Yeah, I think it's something that can be easily learned. It's certainly an what we call in the ultrasound world an angle dependent. So if you don't interrogate the way you're supposed to at the tricuspid annulus and making sure that that is parallel, then you are not going to be measuring the displacement. So what you're interested in seeing how much that tricuspid annulus is being displaced, and that gives you a sense of that systolic function. And usually we say that anything, and different books quote different numbers, but anything that it's below 16 millimeters is considered abnormal. And I think it's one of the parameters that has the most validation, like from PE,
Mhm.
predictor for mortality. So it tells you if it's very low, this patient is at high risk of dying. And other groups have actually validated that in other situations, in not just in PE and pulmonary hypertension, but in other ICU patients. Is it perfect? No. And are there some other parameters that can help you corroborate? Yes. And but it's a good start, Ted. I think it's a good start to understand the right ventricle. If you are just starting, if you look at the size and you have at least one parameter of systolic function, it gives you a better idea than doing nothing, than
Correct.
because there's no other way of knowing how the right ventricle. Yes, there can be some instances where you say, well, this patient is in extremis, but we know that there are many other reasons that the patient can be in extremis or can be short of breath or can have an elevated JBP. Yes, there are some other signs and symptoms that can help you go in that direction, but without visualizing it, it is really hard.
That's right. Yeah. Thank you, Pedro, for explaining that. Pedro, what are some of the important concepts of RV failure management?
Well, I think that, I mean, again, understanding what is the pathophysiology for the RB dysfunction is important because it's going to change your management significantly. What I'm trying to say, is that if you have RB failure because your afterload is increased, it's going to be very different if your RB failing is because you have decreased preload. And I think most of us are familiar with, oh, okay, the RV needs more preload, so it can pump more to the left side, and then the left side will pump to the circulation. But it's not as common as you think. So yes, is the hypovolemic patient, you say, well, the RV is doing everything it can, but it doesn't have enough preload. So I think the scenario where we see the most failure is really from the afterload. And it's going to change management because in most instances, and I'm not saying all of them, in most instances, what you need to do in management is decrease the afterload. And maybe in that patient, you need to decrease the PEEP. Sometimes it's correcting, some of the metabolic abnormalities. Maybe it's the hypercapnia or the hypoxia or some other metabolic abnormalities that need to be changed, to be adjusted or corrected in order to improve that right ventricular performance. So in PE, well, it's very clear that if your RV is failing because there's an obstruction,
Mhm.
then what you need to do is basically deal with that. And sometimes that means getting that clot out, or sometimes that means getting TPA. Sometimes also means supporting the patient with inhaled vasodilators to improve that, to decrease that afterload so the right ventricle can perform better. So basically, it's optimizing that right ventricle, knowing where's that steep part of that Frank Starling curve. And that is not easy, Ted. Many people think it's really, really easy, but it's not easy, especially if you have a chronic condition such as pulmonary hypertension, which is going to be a very different Frank Starling curve for that patient.
Yeah, it's very challenging. I agree with you. On that note, Pedro, can you describe a specific case where you used point of care ultrasound for RV failure and how it helped you?
Yeah, I think I want to start. I work in the cardiac ICU, Ted. So right now, I have a large population of patients with pulmonary hypertension. So it's mostly acute and chronic situation. We tend to get all the referrals for P. So I certainly like to evaluate what is the right ventricular function. And again, I think this is a matter of discussion and controversy, because some people say, well, you already know that there's RV dysfunction. What is the echo or the bedside echo going to tell me?
Mhm.
And I will argue that there's studies that show that if your ventricular outflow, what we call the BTI, which is a surrogate for stroke volume, is low, those patients have worse prognosis. So basically, how bad is bad? That's basically in a nutshell. But it also been very helpful in undiagnosed, shock. Sometimes this patient, I remember my first job, Ted, I had this patient, I had multiple admissions. They tell me he has pneumonia. He had a questionable, infiltrate. And then the patient arrived and had multiple cardiac arrests. And I was scratching my head, what's going on with this patient? And it was the ultrasound that showed me that the patient had a really large RB. There was significant interventricular ventricular interdependence, and I gave the TPA to that patient because that there was no way I could confirm the diagnosis with a pulmonary angiogram,
Mhm.
a CT pulmonary angiogram. I had to say, I think most likely this patient is having this arrest because of the pulmonary embolism, and he has some pulmonary infarct. So it's very helpful in undifferentiated shock because you can exclude that the RB failure is a component of that or is the cause of that. So it's very helpful in that situation, but also in order to kind of quantify a little bit better how bad is that right ventricular function.
Great. Yeah, that's very impressive, Pedro. I'm sure you saved that gentleman's life. So,
Actually, it was very gratifying. Like this patient will come back again and again every 3 or 4 months to say hi to the
oh
ICU,
wow,
saying, "Oh, thank you." Yes, because he arrested multiple times. It was until he got the TPA that basically we were able to stabilize the patient. So yes, it was very gratifying case.
that's a great story, Pedro. What was your experience like during the COVID peak?
It was very intense, and I think it felt very close to home. We had a lot of sick patients in the medical ICU. I was devoted 100% to the medical ICU, and 95% during some of the waves were COVID, and we saw a lot of young men with severe COVID, and we certainly concentrated the most severe cases. So it was quite devastating, to be honest, to especially during the first wave and before we had any vaccines available, and even we were able to help a lot. We also saw the impact of patients which we couldn't help.
Right. Yeah. Yeah. Very difficult times there. But Pedro? What do you see in the future in the field for management of RV failure?
I'm really excited because I think that we're going to get better understanding of all these different phenotypes, and also how we can manage these patients. I mean, the clear example is certainly the PE, because it's a very straightforward, where we're saying, well, this patient has severe RB failure, and what we need is to remove the cause of that. And so is nowadays is aspiration, percutaneous aspiration thrombectomy. So I think that's moving the field in that specific case. But I can see that in other situations, maybe we're better able and focusing, managing the RB, where we said, okay, how can we improve the contractility? How can we, decrease the afterload? And there's this, it's not a new concept, but it's something called RB couplings. It's basically a relationship between the contractility and the afterload. And there are many new echo parameters that will help us understand that. For example, RB strain, that right now the cardiologists use all the time, but it's very possible that we're going to be able to assess at the bedside. I don't have the verdict right now, but I presume that we're going to have better tools basically at the bedside to assess that RB contractility and an afterload relationship.
That's terrific, Pedro. Pedro, what are some of your interests outside the hospital? How does Pedro like to decompress?
Well, I certainly try to be very active, and I some years I do a lot of swimming. Some other years I do a lot of biking, and some years I go more to the gym. So I try to stay very active. As we get older, it's really very important to stay very active. So I do a big effort to balance and stay active no matter what. And I also have a passion for cooking, so I do a lot of cooking in my time off.
Ah, great, great. Is there any type of food or dish that you like to cook?
Well, I'm biased, Ted. I'm Mexican, so I do a lot. I do a lot of tacos for sure.
Yeah. Hey, you can't go wrong with tacos, right? So great, great. All right, Pedro. Well, listen, thank you so much for taking the time out and tackling this very difficult but interesting topic of RV failure and being a guest on MD Roundtable. Keep doing the great work you do, especially with your teaching up at St. Luke's. It's a pleasure having you.
It's been great. Thank you so much for the invitation.
Thanks, Pedro. Have a great day. Folks, if you enjoyed that episode, don't forget to leave a review of MD Roundtable Podcast, and don't forget to subscribe. Also, if you want to reach out to me with any comments or questions, feel free to go ahead and email me at drtedthatchandcarey@gmail.com. Once again, drtedthatchandcarey@gmail.com. I will also leave the email contact in my show notes. Thank you again for joining me. Have a great day.